and pitfalls. For apical window, we put the probe at the apex of the heart and point to the right scapula, and depending on orientation of the probe marker, we can get all those three apical windows views, that apical 4, 2, and 3. Apex of the heart is at the level of the fifth intercostal space, almost a mid-clavicular line. This line and fifth intercostal space. The fifth intercostal is one intercostal below the nipple. So for apical window, we can put exactly one intercostal below the nipple at the midline, mid-clavicular line, then point the probe to the right scapula. For women, that depending on the size of the breast, nipple can move and go everywhere. We can use xiphoid process as a landmark. At the level of the connection of the xiphoid process to sternum will be almost the level of the intercostal space, the fifth one. And so you use that spot and mid-clavicular for finding apex. But as you remember, I talked in the parasternal window, the location of heart depending of the body habitus and position of the patient. For example, people with very big belly and overweight, usually heart will be more horizontal and push a little more lateral and a little higher. So instead of the finding in the fifth, maybe you have to go find at the fourth intercostal space, or opposite in tall and skinny people, usually heart is more vertical and apex move a little lower. So that is a general rules, and for finding the apex, we follow the same technique and principle that we use in the parasternal window. So we go find, we put the probe at the guessed area spot, that apex, and from there with searching circular we can find the correct and actual apex of the heart. For apical 4, we point the marker probe to the 3 o'clock. For apical 2, we just twist counterclockwise 80 to 90 degree, and for apical 3, we continue counterclockwise 20 to 30 more degree counterclockwise. Finally, we get all these three views. In apical 4 chamber, the sector sound passed through the almost center of all 4 chamber, and metamorphically the machine create some the cross section of the upper part of the heart, and it looks like we laying down below the bed of the patient and watching the cross cutting surface of the upper part in this schematic image that you see. Since our marker is at the right side and on monitor as a standard, and we put that the right side of the monitor, this right of the image will be left of the heart and this side will be right of the heart. So let's see apical 4 chamber view has what structure and features. Here we have a standard apical 4 chamber view. We have left ventricular, right ventricular, left atrium, right atrium. We have thoracic aorta, some part of the left pulmonary vein superior, and here if we little angle anterior more, we can see right superior pulmonary vein. Here we have interatrial septum, and sometimes is you see some part is become thin, completely thin, is that will be fossa ovalis. Here we have the mitral valve leaflet, anterior and posterior. here we have tricuspid valve. One is toward the septum, is septal, and the lateral one usually is anterior, but it can be posterior tricuspid valve leaflet too. And shortly I am going to explain why it can be anterior or posterior tricuspid valve leaflet. As we talk in the parasternal lung axis view, the sector sound plate pass through this line here. As you know, this photo is a cephalic or surgical view of base of the heart at the level of the valve. So here is anterior, right side, left side, and posterior. We have pulmonary valve here, aortic valve, mitral valve, left atrial auricle or appendage, tricuspid valve 2. Let's see in apical four-chamber how our sector plane pass through the base of the heart. In apical four-chamber, our sector sound pass through this line, apical 4. So we will see here part of the specific second posterior scallop of mitral valve and the second anterior scallop of mitral valve. And here we have septal tricuspid valve leaflet, and here is anterior of the tricuspid valve leaflet. But if you notice, here is start posterior. From here to here is posterior tricuspid valve leaflet. So if you notice, with this line, if we twist it a little clockwise, our probe just 10 to 15 degree, it will start going to cut instead of the anterior tricuspid valve, it can be posterior or a little angling down toward the bed. It come get this lateral leaflet will be posterior leaflet, but the mid septal one is still septal. So that is the reason always you have to remember exactly how our plane pass through the structure and what the structure exactly can be. About the walls here in the apical four-chamber view, sound sector pass through this line. So this part of the interventricular septum will be posteroseptal. That we in apical four-chamber we called it septum, but more accurate is posteroseptal. And the lateral one is anterolateral wall, this part. As you notice, here we can catch it, some part or all of the anterolateral papillary muscle, as you see in this image, anterolateral papillary muscle. And again, I am going to emphasize, depending of our plane that pass through that structure, it can be different. Just keep in your mind, if you're twisting too much clockwise, instead of the 3, your marker be around 4 or 5, maybe still you have four-chamber view, but that septum will not be anymore posteroseptal, will be anteroseptal. For example, here, if you're twisting too much clockwise and pass through this line that I am showing with the mouse, so this septum is not anymore posteroseptal, it will be anteroseptal. Just keep in your mind when you are evaluating for wall motion abnormality and label it which wall is involved. Now let's go back to the tricuspid valve leaflet. As I said in the parasternal window, in the right ventricular inflow tract, here, this image, our plane is passed through this one, through this line. that is personal lung axis, RVIT view. So the one that close to the probe here, this will be anterior tricuspid valve leaflet. What about this one, the posterior one? Usually, if we are in the right spot, our probe, if we just fan into the left of the hip of the patient, the posterior one will be posterior mitral tricuspid valve leaflet. But imagine if your probe is a little to the lateral of the patient and then tilting, the anterior one, this one, will be septal. So my point is that this anterior leaflet, this is can be anterior mitral valve leaflet or septal mitral valve tricuspid valve leaflet, but the posterior one is always posterior tricuspid valve leaflet. A good apical four chamber view. In apical four chamber view, the apex is clear. We will see largest size of the left ventricular and right ventricular too. Both of the left atrium and right atrium are the largest size. The septum should be almost vertical, and keep it at the center of the sector. For example, in this image, the septum is a little tilting to the left side of the monitor. For fixing this, just slide a little to your probe to your left or medial of the patient, so the septum move to the center. Why I mention this point? Because for getting apical 2 from apical 4, the easiest one and the correct way is that you keep the septum at the center. In that case, with just twisting, counterclockwise the probe 80 to 90 degree without fanning, without angling, it will give you a very typical and classic and correct apical 2 chamber view. If your septum is not vertical, just with heel toe, you can fix it, that problem too. Let's go to the next. One of the most common error in apical 4, 2, and even 3 is foreshortening. In apical 4, a correct apical 4, the sector sound plate should pass through the apex. But if we are a little below that line or above that line, it causes foreshortening. That the length of the left ventricular is off axis and will be shorter than the real and correct size. We called it foreshortened left ventricular. How we can differentiate it between foreshortening and the correct apical 4? As a general rules, when we have foreshortening, the heart is become more round shape compared to the correct apical 4, that is bullet shape, especially left ventricular, and all the heart become more oval and bullet shape. But in foreshortening, heart become more round. Second, and the most important feature is the thickness of the apex at the left ventricular. As we know, the myocardium at the apex and at the basal are the thinnest one. And during systole, the endocardium only move down from the endiastole only a few millimeters, and the thickness of the apex is very thin. Apex is very thin. But if we are foreshortening, the apex not only become thick in the end diastole and end systolic phase, the endocardium move too much down too. When we trace it, we'll notice it's from, for example, if is only 10 millimeter from the epicardium. At the systole time, it goes more than 15 millimeter down. So in that case, it show that foreshortening. The foreshortened left ventricular we cannot use for measurement, 2D measurement, and Simpson for ejection fraction, as you know, because if we use this foreshortened image for ejection fraction, we are overestimating ejection fraction and underestimating end diastolic volume. How we fix this problem? Most of the time, foreshortening when we are above the true apex. In that case, the image very easy go back to 4 and 5 and LVOT show up with patient breathing. You will notice your image goes to the between 4 and 5. So you know a little about the right axis, right point. If you are under the plane and getting image, your image goes easy to the apical 4 and basal view, and you will see the atrium become smaller and the coronary sinus show up here. That is the way you can see I am under the plane imaging or over the correct plane, above the plane. How we fix it based on that where you are is very easy. You put your probe 1 intercostal lower and ask the patient breathe in, and suddenly you will see a correct apical 4-chamber. Here we have one patient at the right side is foreshortening. You can notice the length of the heart here in foreshortening is much less than the correct view in this, and the left ventricular length here you will see is a lot of larger than this one. In another one here is more clear. If you notice this one, this one here is a correct apical 4 and this is foreshortened image. You will see this oval shaped endocardium apex is very thick, and especially during systole become very thick, but here endocardium few millimeter change during systolic phase, and the left ventricular is completely bullet shape. Here is more less than bullet shape, and the heart overall shape is more round compared to the oval and bullet shape of the heart. After we get it and fix the apical 4-chamber, we go for the color on the mitral valve leaflet. As a general rule, again, we put the color box exactly at the level of the area, interest area. Here, for example, we are not covering completely all mitral valve leaflet, so it's better we move a little color box to the left and cover all the mitral valve leaflet. And the tall of the color box is a little high, but it doesn't affect our frame rate. Just we can make it move a little shorter, just cover that area. If you need check other fluid around that structure, that's fine. And as I mentioned many times, the principle for detecting any abnormal jet is surveying or sweeping that area. So when you put color box on the mitral valve leaflet, just sweep or fan anterior and posterior, or toward your face and toward the bed, and slowly and check if there is any jet passed around the mitral valve leaflet or not. When you saw it, you put cursor exactly at that spot. Otherwise, if you don't have abnormal jet, at the center of the both valve leaflet tip, and then you do continuous Doppler. Continuous Doppler, as you know, is only detecting for any blood flow, abnormal blood flow in that area, interest area, and you check it all kind of the flow at that line. Here we have a little trace, as you see, trace negative shift during systole. This is systolic phase. So during systolic phase, we have trace jet here. Just keep in your mind, I am going to explain what is going on later. Here, after continuous, we do pulse Doppler for diastolic dysfunction at the tip of the mitral valve leaflet, and then we measure E and A waves for diastolic dysfunction. And I would like to take your attention and go check out the diastolic dysfunction lecture that I took in detail. After that, we go for the pulmonary vein. This is color box is too much. We don't need it. Just I want to show you how much will be those blood flow in that area. Just we put it, make it smaller, and find the right pulmonary superior vein here. If for finding this, usually you have to a little from apical 4, you have to a little angle up, a little kind of the between apical 4 and apical 5. Suddenly you will see here right pulmonary superior vein. Here we have thoracic aorta, and then we put cursor at the 1 centimeter or a little more inside of the pulmonary vein, and then we measure S and D wave on the Doppler. For in some patient they have 2 S wave. Here at the bottom image you see here for measuring, especially for evaluation diastolic dysfunction in some situation, we measure S2 for our calculation and evaluation. The next step for diastolic dysfunction in the apical 4 is left atrial volume. For left atrial volume, again we go general rules as I talk in another presentation. First of all, we go at end diastole, 1 frame before opening of the mitral valve completely. Then we start at the medial annulus and trace endocardium. We don't include pulmonary vein or any side, or sometime auricle, left auricle. We just trace, and when into the lateral annulus, we double click and the machine calculate for us the left atrial volume. Here at the end, machine give you long axis of the left atrium. Just keep in your mind your long axis should be almost perpendicular to the annulus plate here. If it's not, just move it at this spot, you hold it and grab it and move that area left or right until it becomes perpendicular. As a general rule, your atrium, left atrium especially, should be even and a regular shape, usually rectangle, oval, close to the round. If it's too much irregular, there is 2 reasons. You are off the axis, or you are tracing wrong way, you tracing different structure. Another one, as I mentioned here, you will see aorta, thoracic aorta here. Sometimes because of the angle of the sound, maybe you don't see the border between the aorta and the left atrium wall. So in that case, don't go in here. Just follow imaginary line from the annulus, lateral annulus, and the part of the posterior atrial wall that is clear, and make a nice curve or line at that side, and even almost similar to the intratrial wall at this left side. Then the next step for this evaluation apical for is tissue Doppler on the medial annulus. We go just measure E prime. In some cases, maybe we go measure S prime and A prime too. I am not going to talk in this lecture. You can go to the another presentation that I prepare for you. Then we go for lateral tissue Doppler. You just measure again E prime. And the next step after we finishing diastolic dysfunction measurement parameters, we go for left ventricular zoom for two reasons. One for wall motion, checking wall motion, and second for estimating ejection fraction by Simpson technique. You have to know exactly on your image, you have to see the clear endocardium in almost all spot and segment of the left ventricular. When you have it nice endocardium and clear and correct left ventricular, then we go for tracing and measuring ejection fraction at two spots with traced by Simpson technique, one end diastole and then end systolic. The correct way for tracing of endocardium, I present another lecture. Please check that out in detail. In a different situation, I talk it very in detail. After we finishing systolic and diastolic of the left ventricular, from there we go for the systolic evaluation of the right ventricular function. The first is Tapsy. For Tapsy, as I mentioned in another lecture, you have to put your cursor at the lateral annulus. The way your image should be almost cursor parallel to the movement of the lateral annulus. Then we measure the specific spot, how much move anterior. From here, if you use calculation, just the lowest part to the highest part, the same spot, or just imaginary line here, how much it goes move forward or anterior. This will be our Tapsy, and Tapsy less than 17 millimeter is abnormal and give us some idea there is most probably systolic dysfunction of right ventricular. Only if we don't have heart surgery, or there isn't too much calcification and some pathologic process at the tricuspid and lateral wall of right ventricular. Then we do tissue Doppler on the lateral. Again, the same. Your cursor should be almost parallel to the movement of this annulus, lateral annulus of tricuspid. Then we measure S prime. On this, whenever you have some problem with the right heart, for example, you have RCA problem, infarction in the right coronary artery, or we have pulmonary hypertension, or there are some symptoms, sign of the pulmonary thrombosis and embolism, pulmonary embolism, and we have some dealing for right ventricular function evaluation, just go and measure beside of the S prime, go measure E prime and A prime, and even do pulse wave Doppler on the tricuspid valve. If S prime is less than 10, or E prime less than 8, or A prime is less than 7, we have abnormal systolic function of the right ventricular, and if kind of the diastolic dysfunction, and if E to E prime of the tricuspid valve is more than 6, most probably we will have high right atrial pressure that we evaluate in different way, not in the with tissue Doppler. After finishing apical for those images, we go for apical 4, we go for apical 2. For apical 2, from the apical 4, without fanning or angling, we just twist our probe counterclockwise 80 to 90 degree until we get it very clear, nice apical 2 that is crescentic shape. Left ventricular apex is thin, is not thick, and we will see some part of the papillary muscle, especially in anterolateral papillary muscle at this side. Here we have anterior wall and we have posterior, inferior wall, anterior and inferior wall. If you go back to the cross-section schematic of the image that I showing at the beginning of this presentation, you know exactly what those structures. Here we have on the mitral valve leaflet 3 different scallop of the mitral valve. I'm not going to talk to you about exactly this. Just remind you that in that different angle, a little change on the your axis, it can affect the structure you will get on the apical two-chamber view. For example, here, let me show you, go back to our first slide. Here, as you notice, the in apical 2, our plane passed through this line. Maybe we will see some part of the left auricle, maybe not, depending how much fanning and twisting. And then our line passed through these scallops. As you notice, here is the right one. So we passed through the A1 to A2 and P3. I am not going to talk to you this, just and in the transesophageal presentation, I go in detail. But here, just keep in your mind, depending on how much you twist your probe, and is that you are angling a little to the medial or lateral, you will see different structure and different scallop of the mitral valve leaflet. Here, if you twist too much, you will pass through this line. If you are fanning, it goes different, it get a different structure. The only important things for apical 2, first of all, you have to get it crescentic apical left ventricular, and during scanning, you have to sweep the mitral valve leaflets. In other words, when you are getting apical 2, just fan a little medial and then lateral and sweep all the way of mitral valve leaflet if there is anything. During twisting, if you notice aortic aorta show up, you are fanning to the medial or your left side. In that case, just fan opposite way and continue twisting. The point is that during twisting, you have to keep left atrial open and not showing aorta until you twist 80 to 90 degree, and you will see very clear without aorta. You will see some part of the left auricle, coronary sinus. Here maybe pulmonary vein. This one or two mitral valve leaflet as I talk, and here anterior wall and inferior wall. If you put color here, you notice at that angle you don't see too much, just a flicker here, a little negative shift, suddenly you will see a little, and if you do continuous, you don't see too much jet negative shift on the Doppler. But if you go a little of the axis and a little fanning to the medial or lateral. Here we have off axis of the apical 2 because we are not going in this axis, right? This axis evaluating ejection fraction or wall motion. We are just going to checking any jet, any abnormal jet. So with little fanning, you will see here I lose the left atrium, but my jet is very clear. That in the previous one, a classic apical 2, I didn't have any jet, but here I have very clear 2 jet at the mitral valve, and here we have thoracic descending aorta. Don't confuse with anything. And then we put continuous on that level, and you will see very nice, strong negative of mitral valve regurgitation, Doppler. After doing those left ventricular ejection fraction, we repeated Simpson in the left apical 2-2, and then we go for the last measurement for the diastolic dysfunction, and that is left atrial volume in apical 2. We follow the same rule for measuring left atrial volume, and when we do this, machine calculate for us left atrial volume index. We don't use it only the left atrial volume, we use left atrial volume index based on body surface area. That machine, if we put it height and weight at the beginning before start study, the machine, when we measure both apical 4 and apical 2 left atrial volume, machine give us left atrial volume index. Then we go for the Simpson on the apical 2 again, and almost, if you notice, the ejection fraction between the apical 2 and apical 4 almost is the same. As a general rule, if there isn't any wall motion abnormality and electrical abnormality, the ejection fraction between the apical 2 and apical 4 shouldn't be too much differences. 1, 2, or 3% differences is okay. But if more than 5% there is differences between ejection fraction calculated in apical 2 and apical 4, and we don't have any structure abnormality and wall motion abnormality, then we did in one of those measurements wrong way, and you have to go and fix it, that one. Here we have, I'm giving you some extra tip. Usually it's not in the textbook or other places, but in the practical, you can use this view in many cases, and that will be very helpful. And that is apical 2 of right side of the heart. How we do it? Just from apical 2, you have a typical and classic apical 2. Fan or tilt the probe toward to your left side or more medial, and you little by little you notice the left atrium start disappear, aorta starts show up, and then finally you get apical 2 of the right heart. So this will be right atrium and tricuspid valve. Let me pause it here, right atrium, tricuspid valve, and right ventricular, and maybe some part of the aorta. Especially in this image, you can see here a good apical 2 of the right heart. So you'll see a little of the aorta, maybe not, and right ventricular, right atrium, and very clear, nice tricuspid valve. This patient didn't have a very prominent, clear jet on apical 4 in plaques, I mean RVIT and short axis. But in this view, because this patient very important for I evaluated for pulmonary hypertension, and we need very clear TR. So I went extra and I got it this one. You will see two jet, different, very clear and prominent jet on the tricuspid valve, as you see. Another here is another patient that I use it for some reason. Again, I use apical too. Because of body habitus, here I saw a little more structure beside of the tricuspid valve, left, right ventricular. I see pulmonary vein too, RVOT, and pulmonary valve. Sorry, pulmonary valve. Here, pulmonary valve and aorta. Pulmonary artery, let me pause it. Here. This is RVOT and pulmonary valve. Here is aorta, right atrium, tricuspid valve, and some part of left ventricular and right ventricular. This is again, from the apical too, I fan or angle the probe to the medial or to my left side or right side of the patient without twisting, and suddenly I get it this view. This, believe me, it helps you in many cases, especially when you don't have good windows on plaques, or even you want to see some other structure that you are not sure in the other images. After finishing apical 2, we go apical 3. For apical 3, we just need to twist counterclockwise 20 to 30 degrees more without fanning, without angling our probe. Apical 3 should be the same as plaques. The only differences is more vertical. Instead of the horizontal that we saw in the plaques, is the same as the plaques, just more vertical. So the structure we will see is the same, but we will see more apex. In the plaques we didn't see because we put it at here, and so part of the left ventricular and the other part we will show. But in the apical 3 we will see clear apex, posterior wall, interventricular septum, anterior mitral valve leaflet, posterior mitral valve leaflet, LVOT, and aortic cusp 2. Here we will see and thoracic aorta very clear on this image. Then we go for the color. Here is the cross section of the heart in apical 3, all those structure. Then after that we go for color on one by one. First mitral valve, and then we sweep again. In many cases, actually in most cases, apical 3 give you the best windows for evaluation of jet on mitral valve. That is the best, because almost you can get it jet parallel to this ultrasound wave, and with fanning, a little fanning, heel toe, you can catch any kind of the degree of the mitral valve jet. After finishing mitral valve color, we go for the aortic valve. Then we put color on aorta, and if there is any abnormal jet, as you see here at the here a little of the early diastolic phase, we have trivial AI, and then we do continuous when we have jet on the aorta. If we have any abnormality on the aorta, always we have to do Doppler continuous on pulse in apical 3-2. Here again there is some mistake or error. It's not perfect because the scale is too much high. We can decrease it and use all this free space for our Doppler. Then for the pulse is the same. As you see, you don't see clear peak of the LVOT. So since the size is okay, we don't touch the scale, just we put baseline a little higher. Another tip that I want to give you here for apical, in the apical tree, is apical tree of RVOT. This is not standard and is not in the textbook, but again, I am giving you extra tips in practical field that I am sure you will use it many times, and you will see how much will be helpful. And this is apical tree RVOT. For getting this one, just from apical tree, fan to the your right or left of the patient, or lateral. Fan from the apical tree, fan slowly, gently to the right or lateral, your right or lateral of the patient, and you will notice pulmonary RVOT and pulmonary valve show up here clearly. And if you didn't have good pulmonary view on the plaques or PSACs, in apical help you a lot. Actually, I had a lot of patients with COPD and smoker. They don't have good window on plaques and PSACs, but they have good apical window. In apical window, one of the view that help you check the pulmonary RVOT and pulmonary valve is RVOT in apical tree that I explained here. Another one extra image that usually is not classic and we don't do as a routine is apical tree RVIT. From apical tree, just if you fan to your left or fan up or medial of the patient, from the apical tree, if continue fanning to the midline or medial, all suddenly you will see an RVIT. Is almost the same as RVIT on the plaques, but more vertical. As you see, if there is any jet here, you can make it your cursor completely parallel to the jet on the tricuspid valve. After finishing apical 4 to 3, we go for apical 5, because in apical 3 we check the aorta. Now right after that, continuously we go for the apical 5 and check aorta again in another view. Apical 5. From apical 4 we just fan a little anterior, fanning anterior or up toward the roof, and then also the LVOT and aorta show up. Then we put color, and if there's any jet, as here you will see, we had on the apical tree here, we see 2 on this level. Then we put continuous exactly at the parallel to the jet in LVOT and aorta. Here again, there is some mistaken error on the Doppler. Our scale is too much high and this measurement will not be too much accurate. So always use all this space for spectral. You use it, just you have it here, this free space. Decrease the scale and make it largest envelope that you can have it. So then go for measurement. Here we do repeated LVOTs by sample volume on the LVOT and then trace it. There are some tips that I took in the aortic stenosis evaluation. You can check that out. Another extra image that in apical 5 we can get it is apical 5 pulmonary valve. From the apical 5, in some patient, not all patient, if based on the body habitus, if continue fanning more anterior, aorta disappear and pulmonary valve show up here. There you go. At the end, if you from apical 5 continue fanning more anterior, here we will see pulmonary pulmonary valve, RVOT, pulmonary artery, and we have left atrium, left ventricle, part of the left ventricular, left atrium, and part of the right ventricular here too. That is actually, again, is extra image that's not classic, but in many cases that you don't have very clear pulmonary valve and RVOT in other windows, this apical 5 PV can help you a lot. Here we put color and you will see very nice PI and clear that even you can put cursor completely parallel to the jet. Here is another patient, depending on body habitus, a little orientation change. You will see pulmonary artery here, pulmonary valve not clear. This patient almost didn't have any plaques, parasternal window at all. Then put color the same. If there is any jet, we can check it out. After finishing left apical 5, we go for evaluation of the right ventricular functioning. Besides of that, we did Tapsy and tissue Doppler on the annulus, lateral annulus. We have to do something extra in apical 4. One of them is off axis of the right apical 4. For right that focusing on the right ventricular. As you know, in the classic apical 4, the lateral free wall of the right ventricular is almost parallel to the sound wave. So it doesn't give you a clear and free wall of right ventricular, especially when we have right side problem like right coronary artery problems, stenosis, or obstruction, and we have to see free wall of right ventricular clearly. For that matter, and the right ventricular dimension, we go right apical 4, focusing on the focus on the right ventricular. For this reason and this purpose, we move our probe a little lateral, close to the mid-axillary, or a little more lateral from the mid-clavicular. We move to more lateral, and in that case, free wall become more oblique, and our sound is from parallel get more perpendicular to the free wall and give us more detail of the free wall. If you don't see apex, try to move it down and medial, so you can see all the right ventricular completely. After that, when you have it, you have to measure 2 dimensions, basal diameter and mid diameter of right ventricular. For that reason, that purpose, we go at the end of diastole and we measure inner to inner of the 1/3 proximal of right ventricular, the largest spot. That line is parallel to the tricuspid annulus. Here, the way we measure it, the largest 1/3 basal of the right ventricular, and that line should be parallel to the tricuspid annulus. And then second dimension we measure is mid right ventricular. Mid right ventricular is almost at the middle of the right ventricular, below the papillary muscle, and parallel to the basal dimension. This parallel and inner to inner. Then we measure it. If the basal is more than 41 or mid is more than 35, is abnormal. There is some point I like to mention about the measuring right ventricular dimension. Right ventricular is not actually completely symmetric crescentic, is asymmetric crescentic. Cross section of the right ventricular is not completely symmetric crescentic, is asymmetric a little. And because of the structure surrounded the heart and the moderator band, the basal part of the right ventricular dimension is more than the other part. So for measuring right ventricular dimension, the best view based on the ASE is right ventricular focused apical four-chamber. So we just move the probe to more lateral and we show it free wall and completely right ventricular. But in this image, as you notice, this is a foreshortened of the heart. That is not right. If you have good image, completely right ventricular in apical four-chamber, that is fine. You can use it, that one. If not, just when you go for RV focused apical, just make sure you are not foreshortening of the heart. And beside of that, in apical, when you do apical 4, twist counterclockwise while you keep it the left ventricular largest size until you get larger size of the right ventricular too. So that for measuring right ventricular dimension, we do again with twisting our probe counterclockwise until still we have largest diameter of left ventricular, but we get it largest diameter of the right ventricular too. In that way, our measurement will be correct. Here, as you see, there is another rule for this measurement. If you are not sure in that you are foreshortening or not, just measure both. If both basal dimension of the left ventricular and right ventricular, if ratio of the right to left at the basal is more than 0.66, it is abnormal. After evaluation of the right ventricular dimension, we go for tricuspid valve. On the apical, this is of RV focus view. We put it color. If we can get it color jet and our cursor can be parallel to the jet, that will be fine. We do it. But if not, we go off axis. For example, here, even little we are focusing RV focused apical for the jet. As you see, some part of jet become central, some part of jet in different angle become septal. So in this case, if we put cursor in some part of the jet is not parallel completely. Let's look at here. At that view, the TR jet is maximum pressure gradient will be 22, the maximum velocity 235. But if we go a little off axis of the tricuspid valve, what does mean off axis? We just move our probe more medial. Our probe more medial, especially when there is septal or our cursor is not parallel to the jet. Or very important, we get it very accurate TR for evaluation and calculation of pulmonary pressure. Always, whatever, doesn't matter in apical for standard you have jet or not, always get this extra off axis of tricuspid valve. So just slide a little medial and sometimes a little one intercostal higher, and then you will get it jet that it can be completely parallel to the cursor And now look at how much differences. At the before previous image was maximum pressure gradient 22. Here is 29. Then, as I said, if we are dealing for right ventricular some problem there, it's better to do pulse Doppler on tricuspid valve too. If E is less than 0.35 centimeter per second, or E to A ratio is less than 0.8, most probably we have some kind of diastolic dysfunction of right ventricular. After finishing tricuspid, we go for interatrial septum. It's not mandatory, but it's better always do interatrial septum color in apical 4-2. Just during that color, just don't get one image. Sweep interatrial septum. What does mean? Mean fan anterior and posterior your probe during this color evaluation. You will surprise many times you have interatrial septum defect and ASG or PFO shunt only in apical, very clear, but in the subcostal you don't have very clear image. And the last things I would like to mention about the apical window is superior vena cava entrance to the right atrium. If you are angling basal, a little sometime basal here, this is entrance of the SVC to the right ventricle. That's why I put it this image, because when in bubble test, when you inject the agitated normal saline or macro bubble to the right arm, the bubble start here, and knowing this concept will be helpful in the interpretation of the bubble study that I am going to talk in detail in second part of bubble study presentation.